Tim?
Yeah.
Hi.
Ready to go. Okay, good morning, everybody. Welcome to today's Public Health and Prevention Cabinet panel. Before we start, I need to read an announcement. Due to the coronavirus pandemic, the Council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the Council's website for them to do so. Members of this meeting are asked to keep the microphones and cameras switched off until called to speak, and to switch the microphones and cameras off once they have finished speaking. To indicate a wish to speak, members should request to do so using the meeting's chat function. At the end of the debate on each item of business, there will be a vote. Members should vote using the meeting chat function by indicating for, against, or abstain. I will declare the result after each vote. Officers are in attendance, but will keep the cameras and microphones switched off unless called to speak. Breaks will be incorporated if required into the meeting. So once again, good morning. We have two apologies for absence. One is Fiona Guest, the other is Mark Mills Bishops, and I'm pleased to welcome Seamus Quilty, who's substituting for Fiona, and Sue Featherstone, who's substituting for Mark. At this point, I'm going to ask for members' interests, a reminder about disclosable pecuniary interest and declarable interest. Does anybody wish to declare any interests? I will take silence as no. In which case, we'll move on to the minutes of the last meeting, which was held on the 10th of September 2020. Has everybody got copies of the minutes, and are they happy with the accuracy thereof? Can I ask you to indicate in the chat room? Hello, is there anybody out there? Thank you. I'm assuming that went all right. My machine went a bit strange at that point, but I note from the chat that everyone's agreed. Is that correct? Elaine, can you confirm that? Or Stephanie, rather?
Yeah, there's a majority agreement on them.
Thank you very much. So they're noted. And we move on to actually the one and only item on the agenda, which is a COVID update in all its forms. I'm going to invite, first of all, Andrew Hadfield-Ames to speak and to tell us about the comms strategy and how it's progressing. And then we'll move on to Jim, who will give us a more detailed presentation. So over to you, Andrew.
Thanks, Chair. Please do bear with me if there is a poor signal, but yeah, what I hope to do ahead of Jim's introduction is give a relatively short, possibly 5 or 10 minutes presentation about the current communication strategy focused on local outbreaks, a little bit of an indication of some of the key activities that hopefully members have already seen, but also yeah, try to enthuse and reaffirm some of your roles as community leaders before taking questions. I will be assisted by Nick Pearce, who's one of my senior communications managers within my team, who may just chip in on some of the detailed slides. So first of all, in terms of our overall communications approach to this, we've had 4 key areas, and I'll go through those in turn in a little bit more detail. We launched a really high profile public information campaign, I think mid to late July. We'll show a few examples of those and also some of the early results. Our aim is also to provide a regular or weekly number of reassurance messages. We try to focus on a single activity, location or setting setting each week and share those messages, not just within the county council, but across our health, police and district council colleagues. But also, we really do try to focus in on some of the key areas that Jim's team really ask us to focus on, whether that is a specific district council based on the most recent statistics, or a specific high-risk setting, such as schools, prior to them going back at the start of September. In addition, we've got a forward plan where we try to keep ahead of some of the national updates that we know are coming up, as well as the different events in the calendar, and I'll share with you our current forward plan. So just a bit of a recap in terms of our large county-wide public information campaign that we launched mid to late July. Hopefully a number of yourselves have seen the prominent posters and the artwork that hopefully you feel that's very visual, and I think Jim has given us some anecdotal feedback and positive feedback that by using very consistent messages around 4 key things: wash your hands, keep your distance, wear a face covering, and self-isolate or get tested. There is a star next to that because we have recently separated the self-isolation and testing message following some feedback. And we've really tried to, from launch, make sure that this is a Hertfordshire campaign. So whilst the Play Your Part messaging was something that's been used across the country, we very much used individual case studies of healthcare practitioners, people who are working the pumps in pubs and hairdressers, and used that in the photography and also the case studies that we used. So here are some of the examples. We used a mixture of paid for advertisement as well as utilising existing free or sites that district councils already had access to. We shared our messages in GP surgeries. We did a proactive campaign and did a webinar briefing with our local media, and thanks to them for really endorsing our activity. We also linked in with a number of the major transport networks, and we really did share these messages across our digital platforms and had a really fantastic support across all of the different partners, and it was really pleasing to see. In terms of how that worked, we have had some opinion polling where we can tell a certain proportion of the number of residents who saw it, but these are some of the metrics that we know from our own channels, from our own email newsletter from HCC. We know that around 1/3 of the 90,000 people who signed up to that actually opened that launch email, and we also know that a number of staff and parents, in fact, around 73,000 parents received a text message. We also know that a number of people saw our messaging on social media, and the reach figure that you can see in front of you is the total number of unique people who saw our content versus the number of times people may have seen or had displayed our content. We did use some quite prominent paid for advertising, and that did have a big awareness, but we also circulated print materials through our district colleagues, and have been utilising a number of the leaflets in some of the weeks of actions that we have already talked about. Right at the bottom of the screen, we were also able to work with our internal departments and highways produced the following message across a number of their VMS signs in a number of prominent places. The second area that we are currently working with is very much that reassurance and support activity. Huge amounts of work was done in the preceding weeks before schools going back. We've also been working with our colleagues in the Better Business for All, with trading standards and environmental health officers for shops, restaurants, cafes and bars, providing a number of both digital and print assets into those settings, as well as working internally with our care homes cell, and also working with County Hall colleagues in workplaces and others. I think it's fair to say that since the start of term, we've had a huge amount of press inquiries, primarily relating to schools and a number of infections within those settings, but also in care homes as well. These again are just some of the printed and digital assets that we've supported in recent weeks. So a really significant part of the work that we've been doing in terms of supporting some of Jim's teams has been focusing in on specific localities, and I've mentioned a few there. I'll talk a little bit about how we've done this, but this is really the first phase was about that highly prominent county-wide approach, almost a broadcast approach to try and get our key messages. This is really about letting those residents, stakeholders and staff with a higher risk register know of the situation, and really trying to target and support some of the contact tracing work that has been taking place, as well as some individual comms within some of those high risk settings that I mentioned there. Some of this work has involved increasing the tone of the communications. We have utilised a number of different types of media, developing specific films for a number of the local leaders. We have also tried to really focus in on some of the specific age groups, with the example in Hertsmere around young people, particularly in house parties. So we developed certain materials that really focused in on those areas. We've also targeted those types of age groups through dedicated social media adverts focused at those demographics, but we've also worked with local community leaders in different faith groups. This again just shows how we've been looking to increase some of the tone, but also focus in some of those high risk settings. A little bit more detail on our recent focus. I do think it's worth pausing in terms of a really positive case study that we've done in Hertsmere and with the local district council there. Very much a collaborative effort across communications, environmental health and the political leaders there. We did really turn around some materials very quickly with help from the fire service. We did get boots on the ground and did at least one prominent weekend of action. We also hired a number of really visible advertising vans, and we did really ramp up some of the targeted messages on social media, and I'm really pleased that that's contributed to Hertsmere coming off the area of concern a week on Friday. During this process, we have adapted some of the key messages and work that we have undertaken. We have ramped up some of the tone of our messaging, and sometimes it has been quite stark where it's needed to be. We've tried to do that incrementally. And we've also produced a number of tools and templates that the districts can edit themselves, and we are now looking to systematise this approach that we've developed in Hertsmere and the other areas, so that the district communications teams can take even more of a lead than they've already been doing. And we've also continued to adapt our response as the new tiered system has come on board and the guidance has changed. These are just some more of the examples that I've talked about a moment ago. We've also used a number of creative approaches for those members who are on TikTok, or Instagram. You may have seen Margaret, our dancing Nan, who's trying to encourage a number of younger people to listen to her and her fellow Nans in an engaging way to try and focus on the key rules and do that in a different type of way. In terms of what's coming up, this is the key forward plan. We are, as ever, responding to the new alert levels. We are working on a new infographic and dashboard, which will hopefully provide members as well as residents with that little bit more context around the information. But we are always trying to produce preventative and reassurance messages around things like half-term activities or Halloween. We have also recently reviewed our key messages. We are going to be keeping with the Play Your Part branding, so that does seem to have got some traction. But the Comstel did think that we needed to do a bit more focus on self-isolation following feedback from Jim's team. So we'll be looking at some of those things there, as well as looking to create more emotive case studies of the human side of coronavirus at the same time as testing residents' opinions. And these are just some of the examples that we're producing at the moment around fireworks and Halloween. Finally, Chair, really pleased with members' role in terms of how they have played a really active role in sharing messages today. There is still a continual need for members to continue local communities information. We do have an area of our website where there is a number of tools and templates that members are able to use, but also all of the up-to-date messaging are on our own social media channels for people to retweet. I'm going to pause there, but very happy to take questions or comments. Thank you.
Thank you, Andrew. That's very comprehensive. Any questions? You've pushed everyone into silence, Andrew. I'll give everyone a couple of moments just to think. Nigel.
Tim. Oh.
Hi, thanks, Chair. I just wanted to say thank you to Andrew. That's really interesting. I suppose my only question really is how are you able to judge the effectiveness of the messaging that you're putting across?
So I think we do it in a number of ways. I think there is the the stark side of things in terms of the infection rates, and we are looking to test some of the polls.
It's starting to break up a little.
We're losing you, Andrew.
Of our messages. I'll keep going, but I will stop if you can't hear me. I'll also turn off my video in case that works. I think I think it's also fair to say, Nigel, that we do get quite immediate feedback on Twitter and other things if we don't get it right, and we are quite adept at changing some subtle parts of our messaging, but also we can see how effective things have been when they are shared amongst groups such as Facebook. So we do get some anecdotal feedback from some of those administrators about what people are asking questions on, and also we are responding to that in things like developing new myth-busting information. So yeah. Chair, I can also take a question from Margaret from the chat, if that's okay.
Annie was next in the queue, actually.
Apologies, yes.
Thank
Annie,
you.
would you like to go next?
Yeah, thank you. Thank you very much. Yes, thank you. It all sounds superb. Just a couple of bits, probably two of these Jim might pick up in his presentation. But again, myth busting did stick out to me, to be interested in the new facts that might be out there. And one I was going to ask about, there was something buried in a Sunday paper about surfaces perhaps not being as serious as they thought. Second one was, I don't know whether other members have found this, but quite often in a supermarket, there'll be somebody not wearing a mask that can cause a lot of anxiety to others. I approached the staff and they said they can't say anything because they might have a medical reason. So I just don't know where we are on that, whether we should be encouraging people to wear a badge or something of that idea there. And then the question more specifically to the leaflets. We were all sent some leaflets early on in the pandemic. Are there any updated ones that you'd like us to be putting up on notice boards? And if so, do we download them and print them ourselves, or can we request to have some sent to us? Thank you.
Thank you.
Thanks, Annie. If it's okay, I will answer the final part of that question, but I do know that Jim is going to be picking up certainly the supermarkets issues part of his update, and I think the services one is very much for him to answer. So we are in the process. We are in the process.
Yeah, I'm in a meeting. It's urgent, or can I ring you back?
Whoever that is, Rob, can you turn your microphone off, please? Thank you. Sorry, Andrew, go ahead.
It's okay. So we are in the process of refreshing our materials. We will ensure that there is a printed stock for each member, as well as additional stocks to if you want further copies. So I'll take that back. Thank you. Right.
Margaret, can I before anyone asks any more questions? I mean, Jim will be covering a lot of the technical side of this, so if you can confine your questions about comms rather than perhaps the technicalities. Anyway, Margaret, over to you.
Thank you, Chair. I just put in the chat because I wasn't sure if my mic was going to work all right.
That's what we're asked to do.
So in terms of, you just mentioned that you've separated self-isolate and test, and I am aware how frustrating it has been for people who can't necessarily get a test. And I have been a bit concerned about children and asymptomatic people who actually do need to be tested to help control the virus, really. More adults, I guess, than and student age that might be asymptomatic. And I just was going to ask you to comment on that, and how do you communicate with the public when they can get a test? I know a bit about key workers, but we have had a bit of a problem about that. So I wondered how you were covering that.
Thank you, Margaret. So I'll try and take that in a couple of ways, but I will also ask Jim to pick up on some of the testing capacity in the system. So I think in terms of our core messaging, we did have 4 originally core messaging, and on that 4th one, we did conflate self-isolate and get tested within one key message, and I think somewhere in the last month we have decided to just separate those into a fourth and a fifth. So separate self-isolate because we were getting a little bit of feedback around that being separate to testing. And I do think because of some of the capacity issues with testing per se, and now in addition to that, we are actively looking at the moment in terms of the customer journey. If people are self-isolating during the 10 or 14-day period, about how we can actually continue to communicate with those individuals, not just at the start where we do understand that compliance is quite high, but trying to look at ways in which we can keep that compliance throughout that period, because I think there's some national studies that have shown that it does decline. So I think that's separate. I think that there is a separate swabbing cell, and we've played our part in terms of supporting the various changes to the testing systems. I do think that that the capacity has had impacts in terms of those communications, but I think we've just continued to try to promote the not just when you need to get tested, but also how you can try to apply for test within the capacity. So I'll pause there.
Thank you, Andrew. Tina was next on the list. Tina, would you mind if I ask Jim to answer the question, because I think he'll go into some of that advice in a bit more detail, if that's okay.
Absolutely fine.
I note Susie's comment, which very comforting to see excellent comms, and I think I would support that. I think there's an awful lot going on. So thank you, Andrew. I just know, Ron, you've had a hand waving around there. Were you asking a question, or was it just a hand up? I'll take that as just a hand up, I think.
I think he's on the phone.
Okay. Thank you, Andrew. With that, one of the reasons we put Andrew on first was comms tends to get pushed to the back of a lot of these meetings, and when people perhaps are looking to finish a meeting. So I think it was very useful to have a good run through the whole gamut, if you like, and see exactly what's going on. So thank you. Jim, over to you.
Thank you, Chair. Did you want me to deal with the Remembrance Sunday issue first, while it's still fresh in our mind?
Any order you like, Jim.
Okay, so while I'm stalling for time and trying to get PowerPoint to talk to me, the Remembrance Sunday events, we issued local guidance here which said Remembrance Sunday events can go on. Copies have been sent to all members in the member briefing, and they've gone to all district councils and clerks and the Armed Services Covenant Board. And the Local Government Association has commended our guidance, and I have just put a link in the chat to the Local Government Association's Remembrance Sunday events, if that's acceptable to people. So I think our approach here has been to say to people, what can happen, what can you do, rather than what can't you do, and we've worked on the basis that properly socially distanced, thought through Remembrance Sunday events can be made COVID secure. I'm very happy to talk to any members offline about that, but you'll find all the resources on that link, and if you can't access it, please do just email me.
Jim, is it fair to say, I mean, particularly with events like that to carry them off safely is very challenging? But our approach to this and in fact any other event of community interest has been to try and facilitate rather than stop it happening.
I think that's very fair, actually. I mean, we managed to have the Krishna temple work successfully through their pilgrimage earlier in the year. Eid went off successfully. The Jewish High Holy Days all went off successfully. And we put guidance out for Halloween. even although I'm just a boring old curmudgeon and will just ban it because I just think it's tacky. But sorry, forgive me.
Not an exclusive club.
And now we put guidance out for Remembrance Sunday. It is much more work, because it involves us sitting up in meetings till midnight reading risk assessments. But I think it's better for the population that we put the hours in and help things happen sensitively, especially at this time when many people will be grieving, rather than just saying, no, you can't do it. I think we have to give people a sense of we can get through this pandemic together, which is, I think, the approach we've taken, if that makes sense.
Yeah, and thank you for all the work you're putting in on it. Have you managed to sort out your IT yet?
I have. Hopefully my presentation is on the screen. Can people see it? Oh, thank heavens for that. Right. Sorry, we had a bit of problems earlier this morning at the University Family Justice Conference with people having difficulties. So Teams is a bit shaky today. Some headlines in that cases in Hertfordshire have shown an increase. We're higher than we were in April. It has to be noted that testing is vastly higher than it was in April. So we have 7,600 testing capacity a week in Hertfordshire, just in Pillar 2, the non-NHS testing. Our numbers remain higher than the region, but lower than London and lower than England. The age group with the highest increase remains 17 to 24-year-olds, and I'll come on to an issue about student numbers later. But our surveillance mechanisms show that while hospital beds are rising, so one acute trust alone has 23 patients and a couple of ventilator beds occupied. 111 calls have gone down and remain stable. At one point they were at 220% of capacity and they've gone back down again. And the number of symptomatic people in care homes currently is low, but as we know, this can change in the drop of a hat. And just to remind you that we have national guidance on effective management of COVID that suggests we use the cycle of health protection, which starts with surveillance and epidemiology and works its way through to actions and assurance. None of these stages is problematic, but that's what we're working to in Hertfordshire. And as of 1 minute past midnight this morning, the new tier levels came in, which is medium, high and very high, and government has announced there'll be a further tranche of generic funding to local government to support it. But if you cast your mind back, what happened in June is the government produced a contained framework that had a national watch list, that had local powers, local outbreak funds, required us to produce local outbreak plans, created a joint biosecurity centre, and you may remember that at a rate of knots we stood up an outbreak plan in Hertfordshire within a month. And then in October came enforcement monies and guidance, and I think the latest tranche of measures is an attempt to simplify some of the measures around the country. Hertfordshire is currently in medium. This can change, and I won't go in detail into the restrictions, but our aim is, if we can, to keep the virus as low as possible and keep normal life. That will only happen if our residents keep doing the amazing work they've been doing, but also if we make sure that we deal effectively with situations where there isn't compliance, as well as getting all the measures in place we need to in case it does go higher. Everywhere is rising. Everywhere is rising quickly. So our strategy needs to be to stave off a rise as long as possible. If a rise to a much higher level does happen, in line with other areas, to have a plan to be ready for it, and we are ready for it. I created this diagram around about April or May, or sometime in the fog of spring, and the only change I've made to it is the immunity arrow. So I suggested then that we would have 2 peaks, and here we are in a second peak. We came out, some restrictions were eased over the summer and we're back into a second peak. we're in phase one, the first two peaks. We haven't yet got to control. I think that will be after this peak. I'm hoping that we will begin to enter phase three, which is exit in the new year. I think a vaccine will come for public rollout possibly Q1 of 2021, not Q2, and move to full recovery towards the summer. But full recovery will take ages. This is a large population-wide trauma with multiple impacts. There is no prospect of herd immunity without a vaccine. And the idea that we should just let it rip through is very bad science for reasons I'll come on to. The suggestion is we don't talk about pandemics, but syndemics. And it's not just me going off on one and finding a posh word, but the idea of syndemics has been around for a while in epidemiology. It's the idea that more than one disease or more than one factor interacts with another set of factors to create a kind of bigger whammy, if you like. So we know that with domestic abuse, often adverse mental health, alcohol, drug use and financial stress come together with domestic abuse. And we also knew that with HIV often came with mental health issues, economic issues, racism if you were BAME, and substance use or other challenges. Not always, but it did. And so with COVID, it's not just the virus, but the effects after the virus, it's mental health issues, it's financial stress, it's social isolation, it's a load of things. So we're in a syndemic, and we need to think about multiple impacts which need multiple responses. So this is a graph of cases, which I think shows to me that regardless of the debate about whether this is just an artifact of more testing, our case numbers are going up. And by case, I mean an infected person. I disagree with the view that some people have taken that a case is not a case until it's symptomatic. You wouldn't do that with smallpox. You wouldn't do it with TB. You wouldn't do it with HIV, that if you're symptomatic, you're not a case. Public health action is a salient thing here, and everyone who's infected should be treated as a case in order to suppress the virus. So the public health action needs to be the primary lens, not the clinical action of if it's not infectious or it's not symptomatic, it's not a case. And very clearly, we are seeing numbers ramping up. Very clearly, bed use is going up. Workplace absence from some workplaces is going up. And even if there were many more asymptomatic cases earlier in the year, we are still seeing demand. And I think that needs to be what matters for us in terms of on-the-ground action, rather than slightly more esoteric debates about it's just an artifact of testing. This diagram actually talks about the epidemic phase of the virus. So we had a phase that we might call endemic in summer, where the virus was knocking about, not doing a great deal of stuff, rising and falling, but not having taken off exponentially. And you can see that we came rapidly down that peak, and the purple line is London. The darkest of the blue lines, my mother would call it teal, I suspect, is the east of England. But you can see we came down, bumped about a bit, and then went shooting back up very rapidly in some areas. So the virus is now in epidemic phase. R is above 1, and in fact maybe as high as 1.2, 1.5 in some places. And so we have to presume that the virus will keep circulating exponentially until such times as we get it under control. So we think east of England, our number is up to 1.3. England is up to 1.6. London is higher. It's difficult to calculate an R number on a footprint like Hertfordshire reliably, which is why we haven't done it. We tend to take the regional number or the integrated care system footprint number. I won't dwell on that. And this is our situation report. So you can see, now this might look a wee bit complicated, But you can see on the far right that the prior 7-day incidence rate for Hertfordshire was about 43.4, and it went shooting up to, depending on whether you look at it, 78.78 or 83 per 100,000. We tend to use the last 7 days minus the last 4 days just because it's a better measure of volatility. But the last 7 days would suggest it's gone up to about 55.56, whereas 1 or 2 areas have gone down. There is some suggestion that we might have reached a peak and that the virus is bumping along the peak. I think it's more likely that we will be volatile for some time. And there are some signs that the numbers are beginning to come down, but we are by no means out of the woods yet. And as we know, that can turn in 48 hours due to social interaction. And if I look at this diagram, which gives you cases, and you can see actually in the space of 1, 2, 3, 4, 5 days in Hertfordshire, we had a substantial rise in cases, which just rocketed up due to social interaction. And we are no different to anybody else. This has been a national phenomenon in many areas before anyone says we're worse, because we're not. And you can see the 7-day average, which is the kind of faint sort of lavender-ish line that's kind of done similar over those periods. If we look then at the rise, now this is just a St Albans graph to illustrate, because actually on the St Albans graph it just looks better to read than the others, but it's no different than anywhere else. You can see the largest increase has been in the 17 to 24-year-old age group, followed by the 25 to 39-year-old age group. But sooner or later, it does bleed into more older and more vulnerable populations. So the idea that this will be restricted to those age groups is not borne out by the experience of any nation. You can see also that in terms of hospital beds, we had a large surge during the early part of the year, went down, a bit of a peak in July, went down, and has now started to go back up again. So the idea that the virus isn't affecting many people and that we haven't got many people in hospital beds is simply not true. It is causing demand across the country, including in Hertfordshire. These are the death data. So you can see in April and May, we tragically had a large number of deaths. We had 1 death last week, very tragically, having had almost none, and we had 3 in the last 7 days. This week means the last 7 days, and the week prior was 1. We can't take that as a trend. We just have to take it as very sadly 4 people have died in the last 2 weeks. And that human cost is, I think, what keeps many of us in our team motivated. In terms of student numbers, there's been a significant amount of debate about this. And basically, there is a thing called the NHS digital enrichment process, where laboratory data is run through to find missing contact details. Now, that's entirely sensible. It happens at a national level. It's not us that do it, it's NHS Test and Trace. But it appears that that national database is overriding addresses that may have been provided by the individual at the test centre. So if a Hertfordshire resident went to Newcastle University, even if they provided their Newcastle address at the time of test, it may be overridden if their Hertfordshire address is on the NHS spine. Both addresses are retained in the files, and we've been doing some work on this. I have to say that we're still awaiting the data from the Eastern Field Epidemiology Unit, because this is their data, not ours, and we are awaiting data from the 1st of September onwards. But to show you the effect on 1 week's worth of data, and I've no idea how that graph has come out in those colours, so apologies for everyone's eyesight, but actually in the week to the 1st of October, we had 715 people in Hertfordshire, of whom 473 weren't actually in the county. on first analysis, it would appear. This is being triple checked, which would bring our rate down somewhat substantially in different areas, as you can see there. Now, I hasten to add, this is 1 week's worth of data. I hasten to add that we don't know if this pattern is replicated across the other weeks. I hasten to add this is a national challenge, but you can see that it makes a material difference, not only to our numbers, but also to contact tracing, so that if we're contact tracing people, we need to contact trace people who are there. And some of this is actually borne out by our contact tracing experience when we contact people and their parents tell us at the university, and our responses are, well, we're very sorry. Why does this matter? It matters because actually we need to contact people where they are and do contact tracing where they are. I know that PHE colleagues have taken on the work of helping National Contain with this, and so I want to thank them for the fact that they've agreed to analyse the data and do it because they have the expertise. But this is a national issue, not of their making and not of our making. If I can move on to recent science, so the recent science suggests that a thing called combination prevention, which is yet another piece of jargon, really is the way to go. And the Association of Directors of Public Health, and I am biased, published our guidance on Sunday, which is the first iteration of what this might look like, and I'm very happy to send copies round to everybody. Non-pharmaceutical interventions, so things like face covering and so on, work. We now know we've got 900 papers on face coverings that show they can be effective if used properly and put on and taken off properly. We also know that aerosol spread now is an issue. Not everybody spreads the same amount of virus, and super spreading does happen, which is why choirs can actually be quite safe if done properly, but you may get people who put out a lot of virus. And many musical instruments are now much safer than we thought. But social interaction remains core to spread, and viral particles spread through respiratory droplets remain core to spread. We have seen changes in survival from treatment as we've recognised that COVID is a multi-system infection, not a respiratory disease, and the advent of dexamethasone has seen survival rates increase, and the changes in treatment regime have seen that increase. So we're getting better at treating it and keeping people alive. Combination prevention is often called Swiss cheese, the Swiss cheese diagram. And what do I mean by that? Well, it basically means that you have a load of layers, each of which are inadequate in and of themselves because of holes. So physical distancing and ventilation and masks might fail, but hand hygiene will stop you picking up the virus if somebody has breathed it onto a surface, for example. So it's about multiple layers that improve success and stop the virus getting to you. And we know that worked in HIV, we know it worked in TB, we know it worked in malaria, where we had a variety of layers, and it clearly works in COVID. So multiple layers are the way to go, which is why we have to do multiple things. So the Swiss cheese approach, I suppose you could go for Gruyere or Jarlsberg if you don't like Swiss cheese, clearly works. I think I've covered these, other than to say, again, we don't have a vaccine yet, it's promising. We don't have antivirals yet that are preventive. There are antivirals being used in some treatment and showing some promise. So we're down to, in that Swiss cheese diagram, hygiene, cleaning, disinfection, physical distancing, and disruption of opportunities for the virus to travel, things like barriers and so on, and the use of powers where we need to. And that's the basis of our advice to Remembrance Sunday events, obviously, and then testing, isolating, and contact tracing. The Great Barrington Declaration, you may have seen this idea that it sets up an entirely false alternative between between locking everybody down until we have a vaccine. Well, nobody's proposing that, and letting the virus rip through and create herd immunity. It's bad science for several reasons. The first is 10% of people with symptoms get what we call long COVID, which persists potentially for months, and I'll come on to that in a second. The second is herd immunity is not always possible with diseases. So we haven't reached herd immunity for measles without a vaccine. There's no confidence we will get immunity as a population yet without a vaccine. Some people don't produce antibodies, up to 10% of the population, and that means they could be killed by such a strategy. And there are people who are genetically vulnerable that we can't identify. And finally, immunity wanes over time anyway to viruses, especially coronaviruses. So it is not a scientifically valid strategy. It is not what Sweden did. Sweden had a higher rate of deaths than any of their neighbours and an 8% impact on their economy. So they didn't come out of it as well as people claim they did. And actually our combination prevention strategy, I think, is the only credible strategy currently for us to take. Just moving on to knowing more about, and I think I've only got about 5 minutes left, you'll be very pleased to hear, of clusters of COVID. The latest report from a couple of symptom studies is suggesting we have 6 clusters of COVID. And we don't fully know why, but the first is kind of flu-like symptoms with no fever, where only about 1.5% of people will need hospital breathing support. And then it adds, so flu plus fever, flu fever and gastrointestinal, then you add fatigue, then you add confusion, and then you add abdominal problems. And as you add symptoms, so it gets more severe, and so more people need hospitalisation and breathing support. And we know some things about why that's the case, but not a lot. But that, I think, explains the fact this is not a respiratory disease that is just a bit like a bad flu. There are many people who do get that, but equally there are people who will get very severe multi-system attacks and be very, very ill indeed, and tragically sometimes die. And we now know that we have about 500,000 people in the UK, estimates between about 1.5 and 10% of people with symptoms who develop what we call long COVID, where there can be all sorts of symptoms from extreme fatigue through to a bit of hearing loss, sleep difficulties, hypertension, actually onset of diabetes, and chest pains and palpitations and weakening of the muscles of the heart. So we don't want a simple herd immunity, let it rip through strategy, because in Hertfordshire we'll create 120,000 people in a worst case scenario who will need ongoing health care. I won't go in detail through the BAME work, if I may, other than to say that we have a BAME action plan. We did a webinar the other evening. We're in early days. We need to do much more, obviously. But the issues about BAME populations perfectly illustrate the syndemic point. The kind of many BAME people are in frontline roles. So, for example, pharmacists and nurses, there's an overpreponderance of people from BAME backgrounds, and that's as much due to economic circumstances as it is due to their values of cherishing healthcare and public service that puts them at greater risk. They may be more likely to use public transport, they may have more multiple occupancy houses. So a variety of things come together to increase their exposure to the virus. That plus a whole range of things like racism and stigma and other issues from the PHE report mean that the issues affecting BAME communities are complex, need to be taken seriously, need to be worked through, and I can't do them justice as one mere bit of this presentation, other than to say we are working on it and we need to do more, and we have a local BAME plan, which I've mentioned before, so I won't go into detail again. I just want to say finally that our current health protection tactics remain: keep the county as safe as possible, while moving as much as possible. It is not an either or lockdown or economy. It is a both and held in tension. That's what the best guidance is suggesting. Suppress the virus, work across multiple settings and multiple sources of infection, engage and persuade and motivate our population first and enforce if we have to. And this strategy will work provided the transmissions don't become uncontrollable. And then when we do become uncontrollable, we may have to move into mitigation like the rest of the country, and we've got a plan for that. And if I can leave it there, otherwise I'll go on all day. My apologies for taking quite so long. There are many more slides in this presentation I won't go through, but they're provided for you as background for you to read and look at and use if that's useful. And Chair, if I may, I'll stop there.
Thank you, Jim. Those, as you rightly said, sorry, am I echoing?
No, I don't think you're echoing, Chair, but I'll just mute myself.
Okay. Yeah, thank you, Jim. That was very, very helpful. And just to confirm, the slides I think were circulated this morning. So there are a number of questions on the chat. Nigel asks, 70% of cases are asymptomatic, are they not?
Chair, that wasn't my first question.
Oh, it was the first one on the chat, I think. But anyway.
There was one before that, if I may. It was really on the overall strategy. And is a further rise inevitable? Or do you think, Jim, that we are able to bring levels back down to where they were in the summer or even below following the current strategy?
So this may be me being me rather than me being just dispassionate and scientific, but I refuse to believe a further rise is impossible to suppress. Because I think if we get test and trace absolutely right, if we get contact tracing absolutely right, if we get self-isolation absolutely right, and we get the other measures right, we can do it. We did it earlier in the year. Our Hertfordshire residents were brilliant. I think I heard Andrew, I might have just invented this, but the comms group are working on very detailed, much clearer and simplified comms than around what self-isolation means in a multiplicity of languages, because I think some of the messages have been contradictory from different sources depending on who you read. So we're kind of looking at that as part of that. But I feel I have to believe that we have to give this our best shot at suppressing it. And even if we fail, we'll have slowed it, which will have saved cases and lives. I think that's the first thing.
Yeah, I mean, I guess I'm referring back to the advice from Indy Sage back in July, August, that the government ought to be adopting a zero COVID strategy, which doesn't necessarily mean zero COVID, but a much more aggressive target to suppress the virus. Would you agree with that?
I think the view I would go with, which is the ADPH view, is a combination prevention strategy to suppress the virus as much as possible and balance economy with keeping us safe is the way to do it. I think some of the Indy Sage assumptions feel a bit heroic to me. But whether you call it zero COVID or full suppression is might just be semantics. I think we're probably in the same ballpark.
Okay, thank you.
Okay. Thank you, Jim. Ron Tyndall asked, believes Essex are calling for escalation to tier 3. Is this right? I think it was tier 2, wasn't it?
It was indeed tier 2 they're calling for escalation to.
Right. Anthony Rowland's questionary syndemic.
Yes, Tim, thank you. I hope you can hear me. I've actually got two questions, if I may ask them. Apologies for being late, IT problems. First is a narrow question. At the early stages, one of the things we did in St Albans was to remove or pin back metal gates to parks. I've since seen that has been challenged as a means of conveying the virus or something, and actually something that probably wasn't terribly necessary. I just wondered if Jim has any thoughts on that particular point.
I have to say I'm a great believer in every little helps. So there is evidence that metal objects will transmit it, although outdoors it's probably much less likely. But, you know, if it's an easy thing to do, I think we should do it, because even if its contribution to viral transmission is less than 1%, and we don't know that, it sends a signal to people about being careful and sends a behavioural cue.
Thank you. Could I just then, Tim, just ask the second question, which is a rather broader one, and heard what Jim said about syndemics, and I'm just wondering, in terms of all the different impacts that we might be contemplating as the months and possibly even years pass by, and given that we're a public health panel, and we've spent quite a lot of time thinking about the types of activity that are good for people, and in particular physical activity. I'm just suppose asking a question, are there any things that we as a panel should be looking at proactively, thinking ahead over the next few months and time beyond that even?
I guess the things to put on our forward plan would be, how do we address so if you go back to this syndemic idea of collective trauma and significant amounts of work, we're doing a lot of work as a county council with district colleagues on financial inclusion. So inequalities would be my issue. Early years outcomes, older people, the kind of collective recovery, psychologically and physically, and playing our part in sustainable growth. All of which I think are marathons, not with some quick wins, not sprints. But and I think actually, I mean, if I can take Tim's name in vain, I think our chair actually asked the team to kind of start working on refreshing the public health strategy to kind of look at inequalities much more in light of coming out of COVID. And I know that the Health and Wellbeing Board will be wanting to review its strategy as well. I think there is also something in terms of population health with our NHS colleagues about really getting them to double down again on unwarranted variations in primary care for different populations with different outcomes, as a way of building the health of the population. And if I added something else to my list, it would be workplace health for people who work. So there's quite a large list. I mean, there's enough to keep, you know, me going for another lifetime when we come out of this, as well as all of you and everybody else in the county, I think.
Can I just add to that, Anthony? I think it's a really good question, and thank you for raising it. And I think it sort of encapsulates all the work public health does and needs to do. So you'll note on the agenda that we've got health inequalities coming up at our next meeting. So please keep on us on that one. I think it's important. Where have we got? Margaret, you had a question.
Sorry, can you hear me? Yeah. Okay. I noticed the graph of cases in Hertfordshire, as you just traced up a week of increases, it then went down to 0. Was that a statistical blip, or was that real?
No, that's just the end of the date. So when you get to the date, if the graph program doesn't have numbers, it goes wee and goes shooting down. So I'd love it if it were, but sadly
I thought it was a bit odd, that was all. So, but I was also just going to sort of mention, you know, your Swiss cheese multiple approaches to prevention, really. The only problem was your fast and sensitive testing layer of cheese. That, you know, the rest is under somebody's control, but that one isn't. And it's all going back to testing, really. I noticed Nigel's also got a question about it as to the bung in the works appears to be the lab testing and not having the capacity to do lab testing. And I'm as you heard earlier, I'm particularly concerned about asymptomatic testing when people could be spreading the virus. And you know, I do think people, you know, believe it when they see it. I mean, I think the evidence of the test is really quite important. And I just wondered if we can in any way pressure government to realizing that, you know, the pharmaceutical companies in Hertfordshire did offer to do lab testing, and the government didn't take them up on it, and that would give us better capacity of lab testing. And I suppose I'm hoping that in the future there would be saliva testing, because I think it would be quicker and much, I think, more accurate and much a nicer test for the patient as well. But doing it in Southampton, I hear, on all the students, and I just wondered if you had any news of whether that might become a national test, which could then coincide with different labs doing it, because it will be a different method of the lab testing. But, you know, to get our lab testing at better capacity.
So if memory serves, I think we went over these same questions at Health Scrutiny recently. So again, the Association of Directors of Public Health position is that testing must be absolutely optimal. But that's in the gift of NHS Test and Trace. It's not in our gift. They have decided that symptomatic testing is the way forward because of the shortage of lab capacity, which is out of our hands. I think our view is much wider testing, particularly of asymptomatic contacts. Sorry, I'll get that word right eventually. Is indicated and is important to suppress the virus. The lab capacity has ramped up, but it still remains problematic. We have commissioned our own testing service locally for key workers. We've also commissioned our own testing service locally for outbreak management. That key worker service is now at full capacity. We have a number of mobile testing units in Hertfordshire across something like 7 locations now, as well as a regional testing centre and NHS testing capacity. And in fact, yesterday we asked for more, and I think we may well get more, particularly walk-in capacity. But I think ADPH has called for much greater co-design of test strategies locally. As for saliva sampling, it's still in pilot and it's too early to say. So there's no development there really about national rollout since last time we talked about that, I'm afraid.
Yeah. And can I just one more on key worker testing? In visiting care homes, the problem of family visiting care homes. It was carers in Hertfordshire that suggested this, so I'm not taking the credit for it. They did say, could it be possible for one member of the family who was visiting a dementia patient, rather than be isolated, to become defined as a key worker in Hertfordshire, to be able to have them tested and to make it safe for the care home, and to have that family visitor treated as a key worker.
So we have said we would like that.
Yep.
We have actually asked government if that can be made to happen. It comes with a cost implication for testing and a cost implication for PPE.
Yep.
And as we know, the care home testing process, which is also a national process, has had its share of issues. But we've just revised our visiting policy. I think we are keen to we already have a situation where if a care home feels somebody can visit safely, then we will allow them to visit with those measures taken in place. We'd be delighted to be able to facilitate that kind of key worker approach or key carer approach. I would just say that I take a slight issue with the Methodist Homes Association guidance, because I think it can be read as they're suggesting one test once and that's fine. I think if you're going to designate key carers as key carers, they need to be tested on the same frequency as people who work there. We have also facilitated a number of end-of-life visits in collaboration with the Department of Health directly, where people have had to come back to this country to visit people who were relatives who were dying in care homes, and that has been handled safely and well. I mean, it's extra work, but so I think we are keen to balance keeping the virus out of care homes and under suppression, and enabling people to have a quality of life. Nobody has hit that balance right yet, but if we can do that, I'll be up for it.
Do they have to contact you if there's somebody dying and you need
You need to let someone else get in it sometime.
Sorry. Okay. Is that a policy that is rolled out Hertfordshire wide?
We've got a care homes visiting framework that's rolled out Hertfordshire wide, but there are compassionate grounds on which we can expedite things within hours.
Thank you very much, Jim. That's very helpful.
Annie, you had a question about Swiss cheese and obesity. Annie, are you with us?
I think she might be on mute, Chair.
All right.
Okay, it's coming. There we are. Sorry. Yes, I put my question in there. I noticed there were some adverts earlier on in the first peak from the NHS, Jim. I haven't seen them recently. Is that a direction that we should be talking about, or is that sort of been not really built up at the moment?
In terms of adverts, I think the national government's got much more targeted about adverts, but as you probably heard from Andrew, so have we. So we've got things that people who are young and not ancient fogies like I am get to see, because they use platforms like TikTok that I used to think were sweeties. I think government will start to ramp up adverts, but what they're doing is they're focusing on those areas that are in tiers 2 and 3. And I think there's a bit of an assumption that areas like us will do everything we can to manage by ourselves. I
think an advert's just an example, but because we're public health and prevention, the prevention element of this is quite clear that being overweight, diabetes is a big issue. So is that within our strategy and advice that we're putting out there, particularly with the BAME community?
So yes is the short answer, and we've actually invested more money in weight management and in smoking cessation. So we are seeing, I mean, in fact, 600 people quit smoking for the first peak in Hertfordshire alone, on top of the existing number. So we will keep that extra investment going to help people do everything they can to be as healthy as possible. But the best way to do that is actually target people through GP registers to take up that advice, because we know that clinical targeting at these times is a bit more effective because people are a bit more scared than just blanket advertising. But I mean, if people think we could do more, we will do more.
I think when people are sitting at home thinking, what can we do over this winter? We're very frightened. If there's a way that we can put people in touch, then that could be quite helpful for us to be able to, in our various wards, to be able to do that.
Okay.
I think it's a good point, and I do think we need to look at it, and we will, I think. As Jim points out, we've done it with smoking, so I don't see why we shouldn't be able to do something with obesity and in fact, other issues which make the COVID threat worse than perhaps it might be.
And Chair, I wonder if Annie's possibly suggesting, or this might be in my mind, almost to kind of help your constituents get ready for winter guide for members.
I think that would be useful. It's always useful, isn't it?
I'll make a note of that.
Is that okay, Annie?
Great, thank you. Very good. I like that. Yeah, thanks.
I'm going to jump the list here a moment because I know Caroline needs to get away. So, Caroline, do you want to get your question in now?
Thank you very much, Chair. Thanks, Jim, for your presentation. It's really, really interesting, actually, to see it from your perspective. I'd just be interested to hear your views on what you think is the effectiveness of kind of thermal testing, because at the beginning of the syndemic, I'm using your terminology now, you saw quite a few restaurants and establishments walk in, and they were all very into this whole kind of testing your temperature remotely. And I was just wondering and thinking, I suppose, very specifically about places like schools or universities where you've got or even public transport where you've got so many people at the same time entering establishments, whether you think that is an effective way to kind of monitor if people have a high temperature, or do you think we've moved beyond that? I was just wondering if it's something we would consider, kind of raising the ante on as we move towards winter.
I think this one's quite a complex one, because I think the evidence is quite mixed. There are some people who think it's sensible, but it doesn't. You don't necessarily get a fever with some of the symptoms, so it won't pick out everybody. And I know it's kind of fashionable for some people to kind of pour cold water on an idea on it, but if you take the Swiss cheese combination approach, sorry, other cheeses are available, then as part of a strategy that uses a variety of tools, including nailing the hygiene, nailing the face covering and others, in some circumstances it could be sensible. In and of itself, it's a bit of a waste of time, but in some circumstances it could be sensible as part of a combination strategy, provided you were then acting on it. So we have advised a few people where they've sought to bring that in, and we've said, well, in and of itself, I wouldn't bother. But if you're going to do it with this, that, and the next thing, on that basis, I think the evidence is poor that it's effective by itself. But as part of a combination, why not try it? Does that answer your question a bit? It would depend on the situation. So in a school, it would be probably far less useful than walking into certain office settings where people are likely to spread it rapidly, like or certain food processing plants. So you'd have to pick carefully where you put it.
Yeah, no, thank you for your answer. I mean, it was something that I was discussing with a few schools early on, and I think it was your Swiss cheese analogy that just kind of brought it back to the forefront of my mind again. I just was wondering if, in combination, it's something that you would recommend, or do you think at this stage it's, I'm talking for high traffic situations, because let's say you've got 1,500 students walking in. If you can, get 20 or 30 of those, then that falls into your Swiss cheese analogy, doesn't it? Of that in comparison with everything else.
Yeah, so it's quite interesting that so I've been nudged about my regular cancer follow-up, and I've got an appointment to go for my bloods, and I was told by the cancer centre that you'll have to wear a mask, you'll have your temperature checked. And I thought, well, usually by the time I get to you, I've actually run from the railway station because the train's always late, so that'll be an interesting experience. So some places clearly are using it as part of a strategy. I think it would be, rather than seeing a blanket, yes, I'm quite happy to talk individually to individual situations and look at guidance on that, if that makes sense. Because I think there's some cases where there's not much. I mean, you wouldn't do it in a supermarket, because actually the problem with viral transmission in the supermarket is everybody bumping up against another and rummaging through packages and ignoring social distancing. But in somewhere like certain types of settings, it would, as part of a strategy, yeah, could make sense.
Okay.
Thank you, and thank you, Chair, for letting me jump in. Much appreciated.
That's no problem. I have to say, all this talk of cheese is making me peckish. Can we change it to something else? Ron, you had a question.
Thanks, Chair. Jim, one of your slides was an analysis of the 10 districts where you showed, I think it was in the last week, and I noticed there were 3 or 4 boroughs that were red. Now it's quite a way back. And I know Tim's short time. So what I'm getting at is, what is the actual process? Is there a trigger point a bit further. Is there a trigger point at which, that's the one, you've just passed it.
I'm sorry, it's got a mind of its own this morning.
No, that's the one. I know I'm difficulty reading the top of it, but and I noticed what brought me decorum has got 54. And that's red. So I assume the traffic lights have a trigger point at what percentage is in. And then have you got a set of measures which are then taken? And what is the notification to local councillors? Because I'm decorum and I haven't seen anything come in about us being at 54%.
So I think there's several questions in there. The first is to say these are just statistical measures that are taken from the National Public Health England measures. I think they are going to be revised because the original suggestion for going into tier 2 was 50 cases per 100,000. It's not that anymore, it is different. So yes, we do have thresholds, but these reds on this slide are much more about statistical variation of going up and down. So it's an observed over expected plus 7-day trend, and if you so it's not a definite if you got 50 you're red. It's a where's the pattern going?
Yeah.
I think the second thing to say is that every district council gets a sit rep every day, and the nature of the data sharing agreement with Public Health England is such that it has to go to named individuals and we can't share it widely. The data I'm sharing is taken from the public domain and just plopped into our spreadsheet. So I've taken this from the public facing dashboard and plopped it into our spreadsheet. But there is a situation report that goes to every district council and indeed the strategic coordinating group every day, and that's governed by a very strict information sharing protocol. But this is publicly available data.
Yeah.
So the public dashboard that we produce and the government's dashboard can give you these things. Mm. Does that answer your question?
Yeah, sort of. Yeah, it means I've got to now follow on some local questions. The final, very quickly, Jim. May I share your slides with all the local councillors?
Yes. I mean, I think. I mean, Chair, I'll take your guidance, but given that we're in a public meeting, these slides were shared in a way that can be shared publicly, and I deliberately created quite a long slide deck so that members could use as background.
Thanks very much, Jim. That's great. Thank you.
It would be very strange if we produced them for the public and didn't allow you to send them to councillors.
But I'm very sensitive, especially with that decorum as read. I know the moment I circulate that, I'll be inundated with questions, and so I thought I'd get the questions in first.
You know, at the end of the day, I think it's we could treat everything as read at the moment. We really need to be working hard to get the message out. There's no nuance with this. I think it's let's get the message out there.
Yeah, but that's my philosophy. Yeah, as well, Tim. Yeah.
And I would just say that the fact that there are red things in here does not mean that that these areas are about to go into tier 3. That is absolutely not the case. We are in tier 1 until we change, and these are statistical measures to show fluctuations in virus, not linked to the national tiering system. I can't stress that strongly enough.
It's an indicative chart which it indicates trends.
Yeah, although the version that's on my screen is more likely to kind of indicate eyesight problems.
Okay, well let's move on.
Thanks,
Nigel, you had a further question on testing and lab capacity.
Yes, thanks, Chair. Some of this has been covered by Margaret's question earlier, so I won't. So I'll just build on that, if I may. I've been intrigued for a long while, Jim, with the fact that the positivity of tests are actually so low. I mean, if the only people getting tests are those who are symptomatic, it does seem odd that the rates are usually well below 10% now getting up towards 10%. I just wonder, does this mean we're not targeting testing adequately? And given the blockages in the system, particularly with labs, could we be smarter, or is the system somehow being abused? Are people getting tests when they really don't need them? I mean, it's kind of counterintuitive for me. I've generally been pushing more and more testing, but it just seems to me that, you know, if we are in a resource limited situation, what more can we do to better use that resource? And then on the labs, I mean, you talked a little bit in answer to Margaret about the desire to have, and the fact that we have ramped up capacity in Hertfordshire for our key worker tests and others, but is there additional capacity that could be used? I remember, I think at the last meeting of this panel, you said that one of the mistakes that had been made was standing down the lab capacity that wasn't part of the national system. Is there capacity there that we could use?
So to deal with the first one, the positivity rate is both from Pillar 1, which is NHS staff and patients, and care home staff and patients, some of whom will be asymptomatic.
Okay, yep.
And the positivity from Pillar 2, which is supposedly only symptomatic people. But what we also know is that there'll be a variety of people with symptoms right now that will not be COVID. But the national positivity rate has gone shooting up, and I think if we get a 10% positivity rate, that's, for me, is a sign to be concerned that the virus is circulating widely, yes, which it is across the country. I would, if I could wave a magic wand, I'd be able to do testing asymptomatically on everybody who's been in contact, plus wide testing, so we would get, you know, and we get results back in 72 hours, and we'd be able to really kind of hammer. So I think at the minute this is an artifact of the state of the system, but we have to treat it as an indicative trend that the positivity is going up quite high. So it's not perfect. In fact, none of the disease surveillance systems are far from perfect, and the fact that this has been stood up nationally in a rate of weeks makes that so. So I think, short of getting a really perfect situation of being able to test lots and lots of people, I think we're kind of there. We are where we are with it. In terms of the second one, I think there is more lab capacity that could be stood up. I think there is. We've worked hard to get the Hertfordshire test sites up to the fullest capacity we can, but I think if there was a way of local and national working together where we could ring fence the Hertfordshire capacity for Hertfordshire people, we could probably make more use of that capacity. But that would create an enormous logistical headache for the national system, which is designed to be a national system. So I can understand why they will go, yeah, we know you want that, but you're only interested in Hertfordshire. To which my response would be, well, of course
that's your job.
Yeah. So in an ideal world, I think if we could stand back up the university labs, the NHS labs have now come on stream. More NHS labs have come on stream. Some of the bigger Nightingale labs that had logistics problems have sorted those out. So it's getting better. But again, I would say that let's work together to see what even more we could do to kind of do this. And
I think my main area of concern is, I'm talking to Chris Badger about the testing of care home workers and the delays on getting those test results back, which is, as I understand it, threatening the efficacy of that process. Because if you're not getting the data back within 3 or 4 days, then it's not really much use.
Yes, and I mean I have a 15-point improvement plan for testing. In the same way that we've got one for contact tracing. The difference of contact tracing is we've been allowed to implement it. And but I think that improvement plan would understandably cause a headache for the national system logistically. It could be resolved, but it would be much more work for the initial 6-week period until we sorted it. And they're not there yet. So I think we have to do the best we can to improve the system as much as possible, which may not be ideal, but unfortunately we are where we are with this, and I have ambitions to get it much better, but I suspect they think I'm, probably quite rightly, think I'm busy creating work for national partners, which, you know, they're all working 14-hour days as well. But we have to get better at it.
Yeah.
That's
Okay,
not an excuse not to do it.
Thank you. I do have one other question, but I'll wait till the end, and if there's time, bring me back in, Tim. But...
Okay, well, now do it now quickly, because we know where we are then.
Okay, well, it's a question about school bubbles. We haven't really covered that today, but there's been some concern raised actually by one of my colleagues about the experience at his school where they're not, where his children's school, where if there is a positive case within a bubble, the whole bubble is not being informed of that. Only those that have been those that have deemed to be in close contact, and particularly at young ages, that can be quite difficult to ascertain. So it's a question really about why is that knowledge, which might then affect behaviour in terms of mixing with others, not being shared, not necessarily to tell people to self-isolate, but at least to let them know that someone else in the bubble has tested positive, and then it's up to them to decide whether they've had contact with that person.
So my understanding is that there are arrangements under which all the bubble should be informed, and there is a school, in fact the school's daily incident management team is meeting as I speak. Mm-hmm. We have acted to try and change the size of the bubble so that fewer people need to self-isolate, but my advice is, if anybody is concerned, there is an email address which I can provide members to contact directly the school's COVID help desk, mm-hmm. and they can take this up and act on it. So if you're told to, if it's requirement under our policy to self-isolate, you should be self-isolating. There was some confusion, I think, when the DFE helpline was giving slightly different advice to the National Public Health advice, but that it may be that some people are still doing that. But our advice should be clear, because there's a 3 times weekly bulletin goes out to head teachers to update them on where we are. So I'm happy to look into any issues brought to my attention, if that makes sense.
If you can circulate that email address, that'd be much appreciated. Thanks.
Okay, thank you. Lynn Chesterman.
Thank you, Chair. Thanks, Jim. That was brilliant. Apologies if I've missed something somewhere, but I'm bringing up a bit what Annie was talking about with regard to prevention, and it's mainly about communication. But when we send out for the winter, I think a lot of people got through the summer because they could sit in a garden, or they could at least go outside. When the winter comes and we change the clocks in a couple of weeks, I think you keep hearing people say they've had enough. I just wondered, with the stuff that goes on with prevention, like you, I've been for my cancer follow-up. There's something really going on at the moment. People are not presenting, and could we have some helpline numbers on anything we put out, so that if we are putting out communication, we could have on the back things about the Samaritans, things about age concerned visiting, or something for young people, because I think this next lot, because of the pure winter and the cold and all the rest, could be a lot darker in many ways. Thank you.
If you care to suggest what you think should go on, we'll get them on the information.
I think it's a really good point, Lynn. I've been pressing with the reassurance cell to try and get some central point of contact for a whole range of information for people, so that it's much more easily accessed. We've got lots and lots and lots of information, but it's all over the place at the moment. So I think it's a fair point, and I haven't got there yet, but I'm certainly pressing people to make it happen. So thank you for that. Before I move on to Susie with the last question, because I think we've given us a good airing this morning, Margaret has put on the chat that the phone number and email address for schools will be very helpful, and I think that's already been acknowledged and will be attached to the either the minutes or certainly sent out to the panel in some way or another. So, Susie, you've put a number of things on the chat room, so I'm going to give you last dibs on this one.
Oh, that's very kind, thank you. In fact, my last query was resolved by Jim because he's offered to send me the details. I suppose, having been given the opportunity to talk, I will just very briefly say how enormously impressed I am with the comms and everything they're doing there, which I popped in the chat. And I was just asking about the percentage accuracy of the current tests, but Jim's offered to email me privately. So really, I'm done. Thank you.
Well, that was short and sweet, but thank you very much. And with that, I think I'm going to draw this to a close. And obviously thank Jim and Andrew before for, I think, a substantial amount of information and thought on the subject this morning. Clearly, it isn't going away anytime soon. And we need to be, I think, diligent and get the messages out to people. You know, the very simple messages, they may be becoming a bit boring now because it's the same old message. You know, wash your hands, keep your hands from your face, cover your face in public spaces, maintain distance, etc., etc. As I say, boring, but true. So we are where we are. Thank you all for your attention this morning. We'll meet again. Oh, I'm getting ahead of myself here. We actually need to formally note the report. So can we do that in the chat room? Coming through loud and clear. I think we've got a unanimous agreement on that by the look of it. So thank you for that. And again, looking at item 4, which is a future work programme, it's there for information purposes and for any comment if anybody wishes to do so. So has anybody got any comment on that? I'm going to shoot from silence that they haven't. It's clearly our next meeting. I think it's got a very substantial agenda, so we'll try and get most of that onto it if we can. Any other business? I've not been notified of any. So as I say, our next meeting is on the 9th of December. Thank you all for being with us this morning. Thanks for your attention. And I think some very good questions there. As I said, we're not out of the woods by any means yet. So I think all the input we can get is gratefully received. So thank you very much. Keep safe and see you all soon.
Thank you.
Thank you, Tim. Bye.
Thanks,
Bye.
Tim. Bye, everybody.
Thanks,
Bye.
Tim.
Thank you.